Okay, good morning, everyone. Welcome to ISG Masterclasses. This is the 10th in the series of Masterclass as we started in the month of April. Last Masterclass was on acute and chronic liver failure, and this talk was by Dr. Vivek Saraswat, and this was viewed by almost 1,400 participants live during his talk, and later almost more than 2,000 people have seen this talk on Facebook Live and YouTube. As you're aware that we are keeping all these talks into ISG library, which you can access if you go to ISG website, and there's a portfolio there of ISG library, and all the talks have been kept there for your viewing as per your convenience. So coming to the today's talk, which we believe is important, that is imaging of liver SOLs. And this is a very important problem which we see in clinical practice almost every time, that how do you image the SOLs in the liver? And there are a few more new things have come up, which is liver imaging and reporting and data system, which is called LIRAD, and which was discovered in 2014 and now become a standard of care in imaging of or reporting of imaging of liver SOLs. And what are those? So it's good to know about all these new things about imaging. And we also know that many patients coming to you with reporting to you with liver SOLs, and how do you interpret the liver imaging. So today's talk will be delivered by Professor Dr. Raju Sharma. He's a professor of radiodiagnosis at All India Institute of Medical Sciences, New Delhi. And he has been our, I would say, teacher to us, and we learn lot many things from him every time. A superb teacher and real a gentleman. So we welcome Dr. Raju Sharma for delivering this talk. And to moderate this session, we have Dr. Pankaj Puri. All of you know Dr. Pankaj Puri. Dr. Pankaj Puri is a senior consultant and head of department at Fortis Memorial in Delhi, and he will be happy to moderate this session. With this, I invite Dr. Vivek Saraswat to speak to you before we invite Dr. Raju Sharma for the talk.
Thank you, Govind. Good morning to all the viewers and to the panel. Society of Gastroenterology to the 10th edition of the ISG Masterclasses. As you're all aware, we've started this from the middle of April, about the 16th of April, and it's about a month has been completed with these sessions now. And we have quite gratified at the response that these classes have elicited, the great interest many of you have shown, and high viewership figures. In fact, as Dr. Govind told you last time, the feedback has been so encouraging that we have extended the duration of these classes, and we will be announcing the extended program for the ISG Masterclasses very shortly. As mentioned, today's session is about imaging of space-occupying lesions in the liver, a bread and butter thing for every gastroenterologist and a hepatologist who deals with these problems. This is the first session in this series of master classes that is focusing primarily on investigative specialties, investigative modalities, and not on hardcore clinical topics that we have been pursuing hitherto. The ability to interpret images, to understand them, is very important. And I think one of the key areas where many people who are undergoing, many residents who are undergoing DM training and DNB training need to improve and to understand these things better. So there could be few persons better equipped to teach you about GI radiology and about liver imaging than Professor Raju Sharma. And I'm sure you are in for a treat while we listen to how he helps us understand the imaging of benign and malignant lesions in the liver. With this, I'd like to welcome Professor Raju Sharma and request him to please initiate his talk.
Thank you very much for those kind words and for inviting me. I indeed feel privileged to be amongst gastroenterologists to talk about imaging of focal liver lesions. This is indeed a complex topic, and what I hope to do over the next half an hour or so is take you on a journey for evaluating focal liver lesions. I hope my screen is visible to everyone.
Yes, it is.
So the rapid advances which have taken place in the field of MDCT and magnetic resonance imaging have improved the accuracy of both detection as well as characterization of liver lesions. Another aim is to try and localize these to liver segments as per the bismuth nomenclature for the purpose of surgery. It's also important to remember the background changes in the liver parenchyma because our index of suspicion changes if there is background cirrhosis or HVOTO. So we must remember that we need to evaluate the background liver as well. It's also important to recognize some pseudo lesions like transient hepatic attenuation defects or fusion defects, which can mimic focal mass lesions as they are of no clinical significance and they can be ignored. A new and emerging application of imaging is also response assessment to locoregional therapies, especially in the context of hepatocellular carcinomas. The modalities that are available to us for evaluating liver SOLs, of course, sonography has been there for a long time, but it's essentially used more as a screening tool. It's very useful to distinguish between solid and cystic mass lesions, which have a different differential diagnosis and can help to triage the further workup. We can add on color Doppler at the same time to assess vascularity of the lesion and diagnose entities like pseudoaneurysms. There was much enthusiasm about elastography when it came into force, but it's been that useful, at least as far as liver SOLs are concerned. Of late, there's been a lot of interest in contrast-enhanced ultrasound, which can assess contrast kinetics just like we see on CT and MR. The main advantage, of course, is that it can be used even in patients who have deranged renal function. We use it as a problem-solving technique and find it useful sometimes. CT is really where the money lies, and if you have dual energy CT, it does offer some additional advantages, and I'll show you that. CT, for the purpose of characterizing a focal liver lesion, must be a multi-phase CT. When we evaluate the lesion in the arterial phase, portal venous phase, and the delayed phase, and you'll hear a lot of that as we go along this talk. In the ideal world, the modality of choice for evaluating a focal liver lesion would be MR, because this offers multiple advantages. It has better contrast resolution than CT. It provides multiple paradigms for characterizing liver lesions. You don't just depend on contrast kinetics, but you have the T1 signal, the T2 signal. You can have liver-specific contrast agents like gadolinium bobta, which is taken up by hepatocytes. You can add on diffusion-weighted imaging. So it provides you multiple ways by which you can characterize liver lesions as against CT, where you're essentially looking at the contrast kinetics. However, it is expensive, and also for logistic reasons, we do still land up using CT in a majority of situations, even in tertiary care hospitals. So this is an ultrasound showing you a well-defined echogenic lesion located in the periphery of the liver with very sharply defined borders. And this, in an asymptomatic patient, would be suggestive of a hemangioma in the liver. On the other hand, if you have multiple focal lesions in the liver, which are echogenic, but are surrounded by this hypoechoic halo around the lesion, this is an ominous sign around liver lesions and then becomes suspicious for metastatic deposits. So remember, this hypoechoic rind around echogenic lesions is an ominous sign and should be thought of as in favor of a malignant lesion, most often metastatic deposits. Just a word about contrast-enhanced ultrasound. The agent that we have available in our country is Sonoview, with the compound is sulfur hexachloride microbubbles. This is excreted through breath, can be used even if renal functions are deranged. There are some niche indications. It is really used if your CT and MR are equivocal and do not solve your problem, then sometimes we'll end up doing a contrast-enhanced ultrasound. For the purpose of postgraduates, there is also another agent which has been used a lot in Japan. It's a liver-specific agent called Sonozoid. It is taken up by the Kupffer cells in the liver. The compound is perfluorobutane, has some advantages in the workup of HCCs, but is not available in our country. This is an example of a T1 hypointense, a T2 bright lesion on the surface of the liver. This is after injecting contrast, where you can see this area becomes much more echogenic after the injection of contrast. And then in the venous phase, this washes out, and this fulfills all the criteria for an HCC in a cirrhotic liver. So just like you can assess contrast kinetics on CT or MR, you can assess the arterial phase and the venous phase after injecting the ultrasound contrast agent. Just a quick word about the CT technique. As I said, if you're doing a dedicated CT for evaluating a liver lesion, it must be a multi-phase CT. It's better to use the term multi-phase rather than triple phase because the phases differ from one institution to another. A non-contrast CT is really optional. We don't use it, at least in our institution. We don't find it useful. We acquire images in the arterial phase, which starts at about 30 seconds or 25 to 30 seconds from the beginning of the contrast. Remember, all these timings are taken from the beginning of the contrast injection, which is injected using a pressure injector. Then the venous phase or the portal venous phase comes at about 60 to 70 seconds, and then we acquire a delayed phase at 3 minutes. And the behavior of the lesion across these three phases really helps you in trying to characterize the lesion. We use the late arterial phase rather than the early arterial phase, which comes at about 20 to 22 seconds and gives you contrast only in the arteries. These images should then be read on a workstation. It's no longer the time when you can interpret these images on films because you need to be looking at sub-millimeter slices. We actually take 0.625 millimeter slices and then need to interpret them on a workstation. If you have dual energy CT, we acquire data at different kVs. We won't go into the physics of this because that's a very complicated and time-consuming topic. But when the lower kV images pick up the presence of contrast much better than the higher kV image. So this is from the same data set acquired from a dual energy CT, and notice that the 80 kV image, the contrast enhancement is appreciated much better as compared to the 140 kV image. You can then also generate an iodine map. All the areas which are taking up iodine will then be highlighted on this iodine map. Using a computer algorithm, you can subtract the contrast and you can generate a non-contrast image even after the patient has left the CT room. Coming to MR, MR offers a better contrast resolution. It has a higher sensitivity to gadolinium than CT does to iodine. As I said, multiple paradigms for lesion characterization and superior detection and characterization. The downside being its high cost and the fact that it's a more time-consuming investigation. The shortest protocol for the liver would take about 20 to 25 minutes, whereas a CT we know can be finished in less than 1 minute. Let's now look at what are the features we look at when we are assessing either CT or MR of a focal liver lesion. There's a list of parameters and I'll highlight these with some examples. So on MR, we are interested in seeing the T1 and T2 signal. This is the patient who has cirrhosis. Notice there are focal lesions here. This is a T1 weighted image and that's a T2 weighted image. How do we identify that? Just see the CSF in the spinal canal. On a T2 weighted image, the CSF will be bright. On a T1 weighted image, the CSF will be dark. All fluid containing structures will be dark on a T1 weighted image, and all fluid containing structures, for example, the gallbladder is bright on this image, so it's a T2 weighted image. Notice this small focal lesion in segment 2 of the liver. It's T1 bright, T2 dark. That's how regenerative nodules behave in a cirrhotic liver. So this is likely to be a cirrhotic nodule. On the other hand, notice this subtle lesion in the caudate lobe of the liver adjacent to the IVC. This is T1 dark, but T2 mildly bright. This is the lesion we are more worried about because it is suspicious for a hepatocellular carcinoma in a cirrhotic liver. Presence of a scar within the lesion helps you to narrow down your differential diagnosis. The two common lesions which show a central scar are focal nodular hyperplasia and a fibrolamellar hepatocellular carcinoma. I'll use this T2 weighted image to highlight the appearance of a scar in a fibrolamellar HCC. Notice this central stellate appearance, which is T2 dark, within this large focal lesion in segments 2 and 3 of the liver. This T2 dark scar is virtually characteristic of a fibrolamellar HCC. Fibrolamellar HCCs have a high propensity to metastasize to lymph nodes. Almost 50% of them will show metastatic lymph nodes, locoregional lymph nodes, and these are all enlarged lymph nodes from this large FLC in the left lobe of the liver. Contrast kinetics is really where the money lies, and this is the most critical step in evaluating a focal liver lesion. We see how the lesion behaves in the arterial phase, in the venous phase, and then in the delayed phase. This is the arterial phase in this patient who just presented with pain in the right upper quadrant. We saw this T1 dark lesion, which showed this peripheral nodular discontinuous enhancement, which matches the attenuation of signal intensity of the aorta. So when you see this peripheral nodular discontinuous enhancement around the periphery of the lesion, which matches the blood pool in the aorta, and then on the more delayed phase, the contrast tends to progress towards the center of the lesion, what we call centripetal progression of contrast enhancement, and the lesion retains contrast on the delayed images. we know we are dealing with a hemangioma. This lesion does not need any sampling, no further workup is required, and if the patient is not very symptomatic, it can really just be kept on observation. This lesion does not need to be biopsied at all. On the other hand, notice the heterogeneous enhancement of this focal lesion located in segment 6 of the liver on this CT. And on the venous phase, it shows washout as compared to the background liver. In a cirrhotic liver, when you see heterogeneous non-rim arterial phase enhancement and non-peripheral washout from the lesion, this is suggestive of hepatocellular carcinoma, and we'll see many more examples of this as we go along. Presence of a capsule helps you to narrow down your differential diagnosis. Notice this T1 weighted delayed image showing you this enhancing rind of tissue at the periphery of the lesion, which is the capsule. HCCs in the Asian context tend to be encapsulated more often. On the other hand, lesions like metastatic deposits do not have a capsule. Uptake of liver-specific agents. The contrast agent that we use for liver imaging is called gadolinium bopta. This is taken up by normal functioning hepatocytes, and you can do an image at 1 hour delay from the time of injection when the normal liver enhances, and the lesions which do not contain hepatocytes will be seen as dark. However, lesions like focal nodular hyperplasia, which contain hepatocytes, will be either as bright or even brighter than the background liver. That's the venous phase of the MR of this patient, showing you an avidly enhancing lesion, presence of a small central scar in the center of the lesion. And this is the 1 hour delayed image taken after injection of gadolinium bopta, where you can see that the lesion has taken up contrast, which means that there are functioning hepatocytes within this lesion. And that is really the hallmark of focal nodular hyperplasia and is a very good method of characterizing those lesions. On the other hand, this is a cirrhotic patient. Notice the enhancing lesion in the arterial phase. And then on the hepatocyte phase, this lesion is not taking up any contrast. The background liver is bright. This is the contrast in the gallbladder because this agent has biliary excretion. So this lesion is suggestive of an hepatocellular carcinoma in the appropriate background of cirrhosis. Diffusion weighted imaging is something that we add on to our MR, and you must insist that your radiologists use diffusion weighted imaging because it's very useful. And I'll show some examples as we go along this talk. So this is a high B-value image. Forget about the physics. You have to remember that on a diffusion weighted scan, we acquire low B-value images, high B-value images, and an ADC map. A lesion which is bright on the high B-value image and is dark on the ADC map suggests that this is a very cellular lesion, more likely to happen in malignant lesions, although there are caveats and exceptions, but we leave that for another time. Capsular retraction. This is the dip in the surface of the lesion over this T1 hypointense lesion. Capsular retraction was initially described for the lesion called epithelioid hemangioendothelioma, but we know that it's not pathognomonic of this lesion. You can get capsular retraction in some other lesions also, like mass-forming cholangiocarcinoma. Some lesions have an extensive tendency to invade blood vessels like HCCs. And if you have a lesion in the left lobe of the liver here, which is extending into the portal vein, notice the thrombosed portal vein, there's some enhancement, arterial enhancement within that thrombus. This is suggestive of tumor in vein from a hepatocellular carcinoma. In this different patient, the tumor has extended into the IVC. So remember, hepatocellular carcinomas have a very high propensity to invade the portal vein and the IVC. As I said, the background presence of cirrhosis has to be noted when you're evaluating a focal liver lesion. Notice this nodular contour of the liver with this lace-like fibrosis in the liver, some caudate lobe enlargement, because any lesion within a cirrhotic liver should be looked at with a lot of suspicion for an HCC. So this is the broad spectrum of benign and malignant lesions. There is a long list. We'll try and focus on those that we encounter commonly in day-to-day clinical practice, and we'll skip the rarer lesions. So moving on to the benign lesions, and also, as I said, there are some miscellaneous lesions or mimics or pseudo lesions, and time permitting, we'll look at 1 or 2 examples of these as well towards the end of the talk. Let's begin with the commonest benign focal liver lesion, which is a hemangioma. Hemangioma typically occurs in about 10 to 15% of the general population. Mostly does not produce any symptoms unless it becomes very large, when it can cause pain. It's more common in women, usually in the middle age group. It has a very typical behavior on imaging, although the imaging behavior is somewhat dependent on the size of the lesion. So this is the typical appearance where you have the arterial phase showing you this nodular, peripheral, discontinuous enhancement, which matches the blood pool. This attenuation is almost the same as the contrast in the aorta. You follow it up on the venous phase, this contrast in the periphery, this is increasing and progresses towards the center. And this is the delayed image where you can see more and more contrast is filling up this lesion. There is no washout of contrast, it retains contrast. And this is suggestive of a hemangioma, can be kept on observation, no sampling, no FNAC is required, because even if you do an FNA, all you're going to get is blood. So remember, make a mental picture of this peripheral, nodular, discontinuous enhancement in the lesion, which has a centripetal progression, retains contrast on the delayed image. There is no washout at all. These are the typical features of a hemangioma. This is the MR appearance of a hemangioma. The typical appearance described is that it's very bright on a T2 weighted image, right? It's very, very bright on this T2 weighted image. This is the T1 weighted image where CSF is dark, T2 weighted image, CSF is bright. Notice the T1 hypointense, brightly T2 hyperintense lesion in the arterial phase, again showing you the typical peripheral nodular discontinuous enhancement, which matches the blood pool, matches the signal intensity of the aorta, has a centripetal progression in the venous phase, and this is the delayed phase where almost the whole lesion fills up with contrast. Now, this may not happen completely. The fill-in may not be complete in very large hemangiomas, the giant hemangiomas, because the center of the lesion may undergo fibrosis or thrombosis, and then the whole lesion will not fill up. So there are, of course, exceptions to this common garden variety appearance of a hemangioma that I'm trying to show here. Again, hemangiomas which are smaller than 2 centimeters in size can behave somewhat differently, and we need to remember that. The whole lesion may enhance in the arterial phase instead of the peripheral nodular discontinuous enhancement seen here. In the smaller hemangiomas, which are less than 2 centimeters, the whole lesion may enhance uniformly, and then it may mimic the appearance of hypervascular metastases. How do we differentiate? Again, if we look at the delayed phase, this lesion has retained contrast. It is iso-intense to the background liver. If this was a metastatic deposit, the contrast should have washed out in the delayed phase, and it would have been seen as a hypo-intense lesion compared to the background liver. So the most reliable feature of hemangioma is the peripheral nodular discontinuous enhancement. Additional feature is the fact that it retains contrast in the delayed image. This is the way we look at the diffusion weighted image. This is a low B-value image, a high B-value image, and this is the ADC map. This lesion is very bright on the low B-value image, but it's also bright on the ADC map. This means that it is containing fluid. It's not a very cellular lesion. A malignant lesion like a metastatic deposit would be bright here, but would be very dark on the ADC map. Let's move on to the second commonest benign focal liver lesion, and that's focal nodular hyperplasia. This is again another important lesion for the radiologist, because if we can confidently diagnose FNH, we can again say that the lesion can be kept on observation and does not need to be sampled, does not need to be treated. The hallmark of this lesion is the fact that it shows avid arterial enhancement, becomes isodense to the background liver in the venous phase, has a scar. You can see this kind of a sliced orange appearance of the lesion on this schematic and on this gross specimen of the liver. It shows avid arterial enhancement and this central stellate scar. Notice that this scar enhances in the delayed phase, which means it becomes less obvious because it is taking up contrast in the delayed phase. So a lesion which enhances in the arterial phase, becomes isodense to the background liver in the venous phase, and shows you enhancement of that central scar is suggestive of a focal nodular hyperplasia. This is really a hamartomatous lesion. It's not a true neoplasm at all. It's also been referred to as a stealth lesion because it may behave almost like the background liver, so it's difficult to detect. Notice this very subtle hypoechoic lesion in the liver in the right lobe. On the T2 weighted images, you can barely appreciate this lesion. It's somewhere here. Because of the mass effect on the surrounding blood vessels, you can appreciate this lesion here, but the signal intensity is not very different from the background liver. You inject contrast, and you see that this lesion enhances more than the background liver, and this is the most reliable image on an MR scan for FNH. This is the 1 hour delayed hepatocyte phase, where you can see that this lesion has taken up contrast because it consists of functioning hepatocytes. Let's move on to hepatocellular adenomas. These are seen in the appropriate context of a woman who's in reproductive age group, who's on oral contraceptive pills. This lesion is commonly complicated by hemorrhage and therefore needs to be treated. There's also some risk of a malignant transformation in some subtypes of adenomas, and I'll just talk of that in a minute. If you have more than 10 adenomas, the condition is referred to as adenomatosis. In males, it is seen in the context of athletes who are on anabolic steroids. In the pediatric population, we see it in patients with glycogen storage diseases as well as diseases like tyrosinemia. It's commonly located in the right lobe. It's most often single, more often in the periphery. If you see presence of hemorrhage, which can be detected on CT by seeing hyperdensity or T1 bright signal on MR, or you see the presence of intracellular fat within the lesion, that's when a radiologist strongly considers the diagnosis of a liver cell adenoma. So presence of hemorrhage, presence of fat, especially intracellular fat, avid enhancement on the arterial phase, may show washout in the venous phase. And let me show you some examples. So this is a CT, a non-contrast CT, where you have this hyperdensity within the center of this very large lesion. T1 weighted MR shows you bright signal on T1. There are very few things which are bright on T1. Hemorrhage and fat are amongst them. Then there is a particular sequence that we do on MR. No need to go into the physics of that, but just remember that there is a sequence called the in-phase and the opposed phase sequence, which can detect the presence of intracellular fat within the lesion. Adenomas are lesions which show intracellular fat. This is the in-phase image, where this is the lesion which is mildly bright. Notice the signal drop of this lesion on the opposed phase image, which tells you that this lesion contains intracellular fat. And adenoma is one very good lesion which contains intracellular fat, very mildly T2 bright. You inject contrast, you see avid contrast enhancement of this lesion, which shows washout in the venous phase. On the hepatocyte phase, there is no uptake. The background liver is bright because it has functioning hepatocytes. This lesion is dark because it does not contain functioning hepatocytes. Based on the imaging features, there are 4 different subtypes of adenomas. We won't go into the details of this. We leave this to the radiologist, but remember that your radiologist can sometimes help you to subtype the type of adenoma based on the imaging characteristics. The commonest is the inflammatory subtype. Second commonest is the HNF1 alpha mutated type of adenoma. The third and the more ominous adenoma is the beta-catenin mutated adenoma, because this can progress into a hepatocellular carcinoma. I'm not going into the imaging features which help you to subtype these in the interest of time, but just want you to remember that subtyping of adenomas based on this classification which came out of France can be done using MR. Another example of signal drop on the opposed phase image. This is liver cell adenomatosis. More than 10 adenomas in the liver. That's the in-phase image, that's the opposed phase image. And see the very marked signal drop. Signal drop means that these lesions become very dark on the opposed phase image, which is what could help us in making a diagnosis. Moving on to biliary hamartomas. Biliary hamartomas are relatively rare benign lesions. They arise from the biliary epithelium, but they do not communicate with the biliary tree. The hallmark of this lesion on imaging is that they are very bright on T2. They are multiple, they are numerous. When they are seen, they virtually stud the entire liver. They are usually equal in size. You can see almost all the lesions are similar in size, less than a centimeter by and large, do not show communication with the biliary tree. Then you should be thinking of biliary hamartomas, what has also been referred to as the von Meyenberg's complex. The differential diagnosis of this lesion is from microabscesses. This was a patient who had biliary dilatation, also had cholangitis, and we had a lot of discussion with our gastroenterology colleagues. Why are these not cholangiole abscesses? And the reason is that they are too numerous. They are all same in size. They did not show any enhancement when we injected contrast. So we were certain that these are biliary hamartomas and not cholangiolar abscesses. Remember that they are biliary hamartomas. They do not communicate with the biliary tree. Moving on to some rarer benign lesions. This is a biliary cyst adenoma. Biliary cyst adenomas are seen more often in women, almost exclusively in women, middle-aged women. It's a multi-septated lesion, which may show you nodular projections from the wall. It can show you septal calcification. This lesion, in the Indian context, is reminiscent of hydatid cyst And we would always keep that differential diagnosis with few features which help you to distinguish this from a common garden variety of hydatid. Remember, hydatids typically show daughter cysts in the periphery. They do show septae, but usually the septae will not show calcification. In the Western population, when they see a lesion like this, they only think of the possibility of a biliary cyst adenoma. But it's important to remember that in our country, hydatid cyst can very closely mimic the appearance of biliary cyst adenoma. Liver cyst is, I'm just mentioning it in passing, this is a lesion which is of no consequence, but you need to differentiate it from cystic metastases. This is the CT appearance. You have these multiple water density lesions. These are simple liver cysts which arise from the biliary endothelium. They are congenital lesions. They are usually well defined. They can be of different sizes, ranging from millimeters to up to 20 centimeters. They usually do not show thick septations. They may show very fine, thin septations. They do not communicate with the biliary tree. If you see more than 10 such lesions in the liver, you have to think of the possibility of a polycystic liver disease as well. This is the MR appearance of a different patient where you have a T1 dark lesion, T2 bright lesion. You inject contrast, there is no enhancement at all in any phase. And when you see this combination of imaging features, you know you're dealing with liver cysts, simple liver cysts. We need to distinguish these again from hydatid cysts in our country. Remember, unusually hydatids can be unilocular, and a single hydatid can sometimes mimic a simple liver cyst and may need to undergo aspiration to prove the diagnosis. I think with that, we could take a short break. We can take a few questions. I am done with dealing with benign liver lesions, and after we've dealt with some questions, we can move on to the more ominous malignant focal liver lesions.
Professor Raju, there are so many questions and you evoked such a strong response from so many people, and I'm going to try and filter and reach some of them because it's going to be a class of its own if I try and finish all of them. So let me ask you some of the questions which have been asked by the audience. And first is from Suprabhat Giri from Mumbai. And his question is, how do you differentiate hepatocellular adenoma from HCC?
So firstly, the clinical context is very important. Remember, I said adenomas occur in reproductive age group women who are on OCPs. They may show hemorrhage, and they do show a lot of enhancement, and they can show washout. HCCs typically are seen in the cirrhotic liver. And so if I was to say, if you have a non-cirrhotic liver and the patient is in the reproductive age group, the two can mimic each other very, very closely, because you will get arterial enhancement, you can get washout, especially the beta-catenin mutated variant of adenoma can very closely mimic a hepatocellular carcinoma unless the clinical context is different. If you're dealing with a cirrhotic patient with that morphology, we'd be thinking of a hepatocellular carcinoma. If we have a patient who we know is 24 years old, is on oral contraceptive pills with the same morphology, we would be thinking on the lines of an adenoma. So very good question. The clinical context is of course very, very important. And there are types of adenomas which can very closely mimic HCC, in which situation we would go ahead and do a biopsy of the lesion.
A few more related to HCC. And next one is Jayanta from Calcutta. And he's asking, how can we differentiate capsulated HCC and liver abscesses in a CT scan?
I think allow me to go through the spectrum of HCCs, and I'll take this question in the second part, because by the time I would have highlighted the features.
And specifically, any indications of image guiding biopsies for diagnosing HCC? I mean, or should we ask all the questions related to?
I think that may be better if the questions for HCC come in the second part of the talk. That would be better. I can take questions on benign lesions at this point.
So next one is focal nodular hyperplasia versus cirrhosis with dysplastic nodules versus metastatic disease. This is Anand from Chennai.
So focal nodular hyperplasia is a very gratifying lesion for a radiologist, because using MR, we can really characterize this lesion very well. Again, the clinical context is absolutely vital. We will never be able to diagnose FNH in a cirrhotic liver. Lesion like that would be considered a regenerative nodule or a dysplastic nodule. In a non-cirrhotic liver, when you see a lesion which shows you arterial enhancement, becomes isodense to the background liver and shows you a central stellate scar, which shows delayed enhancement, that is what an FNH looks like. You inject gadolinium bopter on the 1 hour delayed phase. If that lesion takes up contrast, it is an FNH. This I'm talking of a solitary lesion in a non-cirrhotic liver. Moving on to a cirrhotic liver, if you have a focal liver lesion, which is T1 bright, T2 dark, takes up gadolinium bobta, because we know regenerative nodules have functioning hepatocytes, that lesion is likely to be a regenerative nodule or a dysplastic nodule. So the clinical context, the background liver parenchyma, is there cirrhosis, is there no cirrhosis, going to make all the difference. Remember, FNHs are solitary lesion. They usually occur in a non-cirrhotic liver. FNH commonly occurs when there is a vascular anomaly in the liver. You know, patients who have NCPF, patients who have Abernethy shunts, congenital extrahepatic porosystemic shunts, they are the ones who develop FNH. Regenerative nodules and dysplastic nodules exclusively occur in the context of cirrhosis or HVOTO. So I think the background liver helps us make that distinction very well.
So a follow-up question from Anand from Chennai again. He says, sometimes it becomes very difficult to differentiate a dysplastic nodule from typical regenerating nodules. And really, if you have any tips to try and differentiate between the two.
So that's absolutely correct. Dysplastic nodule can be very difficult and challenging to distinguish from an early HCC also. Remember, a dysplastic nodule is not T2 bright. It can show arterial enhancement. Rarely it can show arterial enhancement, but does not show venous washout, right? So a lesion which is T2 dark shows you some subtle arterial enhancement, but no venous washout, is more likely to be a dysplastic nodule. It will not show restriction on a diffusion weighted image. Whereas in HCC will be T2 bright. The hallmark is arterial phase, non-rim enhancement, and I'll show you many examples of that, venous washout and presence of a capsule. So there are features which can help you distinguish, but I agree there are some dysplastic nodules which we keep very closely on follow-up because we are not sure, is it an early HCC which is developing within the dysplastic nodule.
So next one is from Pierre Ratna from Sri Lanka, and he's asked, what is the best imaging for a liver hemangioma?
In the ideal world, definitely an MR, a contrast-enhanced MR is the ideal tool which can diagnose with a lot of diagnostic confidence. But if you don't have access to MR or cost considerations are there, a multi-phase CT is the next best substitute.
Next one is Vineet, and he's asked you a technical question on the rate of contrast infusion and the timing from the start and finishing of giving contrast.
I would imagine that question would come from a radiologist. Okay.
Well, I think, Matt, if you don't give the contrast correctly, you're not really going to time your phases well.
Absolutely. I think the contrast injection is absolutely vital and critical step in a CT. We always use a pressure injector. So for a good contrast enhancement, you need a pressure injector. We would inject about 3 to 4 ml per kg body weight. The rate can be about 2 to 4 ml per second. And the key element is that you have to use a pressure injector, use an appropriate volume, which would be about 80 to 100 ml of contrast. And the iodine concentration in the contrast is also very important. The iodine concentration must be more than 300 milligrams of iodine per 100 ml.
Okay, this is Dr. Subhamoy Das from Kolkata, and he's asking about differentiating benign cystic lesions and the possibility of HCC and T1 imaging.
So only on T1 you would not be able to do it. You would definitely need to inject contrast. As I said, a simple cystic lesion will show no contrast enhancement, whereas an HCC will show you definite arterial phase enhancement. You definitely need contrast. I think that concept of doing that we can do give a diagnosis on MR without contrast is wrong. Whether it's CT or it's MR, you need to do a multi-phase contrast enhanced study with arterial, venous, and delayed images. There is no substitute to that at all.
Doctor, can we go to now talk and then we come back to questions a bit?
I think it's a full class by its own. Okay. Yes. I think we should take a pause here. And okay, Dr. Raju.
Okay, we'll move on to seeing malignant focal liver lesions. And here, of course, the commonest lesion that we encounter in day-to-day practice that is relevant to the gastroenterologist is hepatocellular carcinoma. Although overall, if we talk about incidence, metastatic deposits are perhaps more common. But I know the audience that I'm speaking to, HCC is the more relevant lesion, and I'll try and focus on this. So we remember 80% of HCCs occur in the cirrhotic liver, and therefore the background liver, the appearance of the background liver is absolutely vital when we're evaluating a focal liver lesions. Ultrasound is a good screening technique. ASLD recommends 6-monthly ultrasound for surveillance. But remember, ultrasound has a fairly poor sensitivity for picking up small HCCs because you're looking for a focal lesion in a liver which is very heterogeneous, and it's very hard to detect HCCs. So some centers would even use CT or MR, even MR, for the purpose of surveillance as well. HCCs come in 3 different flavors. It could be a solitary lesion, you could have multifocal nodules, or you could have the least common variety of a diffusely infiltrating HCC. They are more often encapsulated in the Asian context, and as we alluded to earlier, it has a high propensity for vascular invasion, both going into the portal vein as well as the hepatic veins. Let's jump into seeing some examples. So this is the arterial phase. Notice that the arteries are enhancing very well. There is this heterogeneously enhancing lesion in the right lobe of the liver. You can see a supplying vessel coming from the right hepatic artery here, and this lesion shows you venous washout. One concept that I want to clarify is regarding venous washout. When we talk of venous washout, we compare the lesion to the background liver. We do not compare the appearance of the lesion to the arterial phase appearance, right? So when we say venous washout, the lesion must be hypodense as compared to the background liver, which is what this lesion is doing. So heterogeneous enhancement in the arterial phase, and there is washout in the venous phase, and this is the delayed phase. Also look at the right branch of the portal vein. There's almost direct extension of the tumor going into the portal vein. So there is venous extension of this lesion, and in a patient who has chronic liver disease, this would be diagnostic for HCC. And if you have findings like this, you really don't need to biopsy. Arguably, HCC in a cirrhotic liver is one of those lesions which does not need biopsy for treatment if the imaging findings are unequivocal. So ultrasound has a poor sensitivity for detection. CT does a much better job, but it's MR which does the best job here. And in the cirrhotic liver, detection and characterization of liver lesions should ideally be done using contrast-enhanced MR. What are the hallmarks of an HCC? Arterial phase enhancement, which is non-rim, and I'll show you why this is important. So non-rim arterial phase enhancement, quick washout, which is non-peripheral, and added feature is capsular enhancement on the delayed phases. So that's just an algorithm which you're all familiar with. If you have a nodule detected in a cirrhotic liver, if it's less than 1 centimeter in size, you need to then keep it on follow-up, repeat ultrasound at 3 months, and assess the change in the size of the lesion. Lesions which are larger than 1 centimeter in size, then you do a CT for characterization or an MR, depending on the choice of your institution. If you see all the definite features, you know you're dealing with an HCC. However, if the findings are equivocal on CT, you could then switch to doing an MR and assess those features. If the findings remain equivocal after both CT and MR, it is only in those patients that we go ahead with a biopsy of an HCC in a cirrhotic liver. So these are the different morphological appearances. This is an arterial enhancing solitary focal lesion in the liver. These are multifocal arterial enhancing lesions. And this is the least common variety, which is a diffusely infiltrating HCC, which can be very, very difficult to diagnose on imaging. So this is an iodine map from a patient who had chronic active hepatitis. And we picked up this focus of arterial enhancement. Notice that it becomes just very easy to detect this on the iodine map. Wherever there is iodine, this will show you a color code, and that just makes it much easier to perceive, although the information is there on this image also. These are the arterial, venous, and delayed images of the same patient. Notice that sometimes you may not be able to see clear washout on the venous phase, and that may occur in the delayed phase. Notice that this very subtle lesion here is now hypodense as compared to the background liver. So it shows you enhancement, which is non-rim. It shows you venous washout, and you know that you're dealing with an HCC. A nomenclature that has been introduced to describe the liver lesions is the LIRAD nomenclature, and it's a good idea to be familiar with this. LIRAD is a separate talk in itself, so I won't go into too many details, but I just want to introduce the concept of LIRAD. This is to bring the gastroenterologists and radiologists on the same page. It's similar to the BIRAD nomenclature, which is widely accepted in breast cancer. But increasingly, we want all of you to use the LIRAD nomenclature. We use this in our radiology reports. It's a good way to be on the same page to communicate. And this basically grades the degree of suspicion from LR1 to LR5 LR1 is a definitely benign lesion, and LR5 is a lesion which shows all the typical imaging features for HCC, and I'm going to virtually say that this is HCC and no further biopsy is required. What are the features? So we need to divide this on the basis of size into less than 1 centimeter or more than 1 centimeter, arterial phase enhancement, which is non-rim type of arterial phase enhancement, and the additional features are presence of a capsule, non-peripheral washout, and threshold growth. Then there are some ancillary features, but we'll not go into these details because we don't have the time for doing that. So let's look at another example. This is the patient who has cirrhosis. Notice this subtle but heterogeneously enhancing lesion. This is the arterial phase. There is arterial enhancement within the center of this lesion. This is the portal vein, which is showing you a thrombus, but there is arterial enhancement of that thrombus within the portal vein. The portal vein lumen is distended, as can be seen here. This is the portal vein. These are the thrombosed branches of the right branch of portal vein. This is the lesion which is showing you washout. So remember, arterial enhancement, venous washout, which means the lesion has become hypodense as compared to the normal enhancing liver. The portal vein is distended. There is direct extension of tumor into the portal vein, and there is arterial enhancement of that thrombus, which tells you that this is tumor thrombus, what is better referred to as tumor in vein by the current LIRAD terminology. So this is the kind of lesion which your radiologist is going to describe as LR5 with tumor in vein. This is definitely HCC, no sampling is required. The presence of thrombus, as you are better aware, is important to convey to your clinicians. This patient is not a good candidate for TACE at all because the portal vein is already thrombosed. Looking at the MR appearance, I'm going to skip the theory description and just jump to the example. So this is the T1 weighted image. There is this well-defined lesion in the right lobe of the liver, which on T2 is heterogeneously hyper intense. This is the arterial phase, which shows you heterogeneous enhancement even in the center of the lesion. And on the delayed phase, there is a capsule. Again, it shows you all the hallmarks of an HCC, and this would also fit into an LR5 lesion. Yes, another example. The contrast kinetic phase is the most important phase, whether you're looking at CT or MR. That's the arterial phase. Notice this very heterogeneously, avidly enhancing lesion in the right lobe of the liver, background liver showing you changes of cirrhosis, nodular contour. This is the arterial phase. In the venous phase, the lesion shows washout. It has become less intense as compared to the background liver. In the equilibrium phase, you have the presence of a capsule in the periphery of the lesion. This is the 1 hour delayed phase. And one caveat to what I was talking in the context of FNH earlier is the fact that well-differentiated HCCs can have some functioning hepatocytes. So it may show some bright signal on the hepatocyte phase, but that will be patchy and not uniform, as in the case of focal nodular hyperplasia. So this slide is really very, very important, shows you all the imaging features of diagnosing a hepatocellular carcinoma in a cirrhotic liver. Let's try and assign a LIRAD category to this another example of a focal lesion in a cirrhotic liver. This is the arterial phase, showing you a lot of enhancement in the arterial phase. This is the venous phase, showing you washout. That's the T2 weighted image. This is the portal vein. The portal vein is distended, and there is hyperintensity within the portal vein. Let's go back to our LIRAD table. Lesion is larger than 2 centimeters. It shows you definite arterial phase non-rim enhancement, shows you venous washout. We know that this is a lesion which can be categorized as LR5 since there is thrombus in the portal vein, which looks like a malignant thrombus. So we're going to call it LR5 TI with tumor in vein. In the context of hepatic venous outflow tract obstruction or Budd-Chiari syndrome, it has frequently been said that HCC is very rare, and that's true. But occasionally, if you're working in a tertiary care center, you will encounter HCC arising in the background of a Budd-Chiari syndrome. This is the typical arterial enhancing lesion showing you venous washout in a patient who has background HVOTO. There are no normal hepatic veins seen here. This is the dilated caudate vein, and that's the enlarged caudate lobe. Very dysmorphic liver because of the presence of Budd-Chiari syndrome. I'm not going into the details of staging for HCC in today's talk. We follow the BCLC staging because that helps you to triage patients into the appropriate arm of management. And you're already aware of how the BCLC staging is applied along with the clinical status of the patient. Let's move on to seeing some variants. Fibrolamellar HCC occurs in young adults, occurs in a non-cirrhotic liver. The serum alpha-fetoprotein, which is a good marker for HCC, is normal in fibrolamellar HCC. They are associated with a better prognosis. The hallmark is again the presence of a scar. That scar may show calcification. If we compare the scar of a fibrolamellar HCC with the scar of focal nodular hyperplasia, presence of calcification, T2 dark signal, no enhancement are the features of scar of fibrolamellar HCC. That's a typical example. Notice this very subtle focus of calcification on CT seen in the central scar. That's the MR T2 weighted image showing you that it's T2 dark. The scar of FNH is T2 bright. And this is the contrast enhancement, contrast enhanced phase showing you a lot of enhancement, but the scar is not showing enhancement. If this was an FNH, this scar would be bright on T2 and it would show enhancement on the delayed phase. There's a long list of differentials for HCC. We won't have the time to go into all of these, but remember we have to distinguish HCC from the commonly occurring regenerative nodules and dysplastic nodules. And I talked of that in answer to a question in the break. Then confluent hepatic fibrosis typically occurs in the anterior segments of the right lobe, is associated with capsular retraction and shows delayed enhancement. NRH and HVOTO, and of course, arterioportal shunts can also mimic hepatocellular carcinoma. The other common lesion which can occur in the cirrhotic liver, the second commonest malignant lesion in the cirrhotic liver is a mass-forming cholangiocarcinoma. Mass-forming cholangiocarcinomas show you more of peripheral enhancement. They're associated with dilated biliary radicals and they show delayed enhancement. They do not show too much washout. Because of a fibrous stroma that these tumors have, they show delayed enhancement, right? So if you have a lesion which shows more of rim or peripheral enhancement, is associated with dilated biliary radicals, may be associated with some capsular retraction, and shows delayed enhancement, think of the entity of mass-forming cholangiocarcinoma. Let's do another example of LIRAD assessment. This is a lesion which shows you typical peripheral rim enhancement. So this is rim enhancement. Only the periphery of the lesion is showing you enhancement. This enhancement tends to have some centripetal progression, and on the delayed image shows you more enhancement, right? So very atypical for an HCC. So this is a lesion which appears to be malignant, but is not showing you the features for an HCC. It's larger than 2 centimeters, shows you rim enhancement, does not show washout, there is no capsule, there is subtle biliary dilatation, and there is some delayed enhancement. This on LIRAD is classified as an LRM. It is likely to be malignant, but is not suggestive of HCC, and this is likely to be a mass-forming cholangiocarcinoma. Why is it so important? Because you know that this patient, if you're working in a transplant center, goes off the transplant list because transplants are not done for patients with mass-forming cholangiocarcinomas. So I hope I've got the point right that mass-forming cholangios show you rim enhancement, are associated with subtle biliary dilatation, and they show you delayed enhancement as well. There is no significant washout, which is the opposite of what we get in hepatocellular carcinomas. Occasionally, you can get a lesion which is biphenotypic. This is a complex area, and we'll not delve into the details of this. Leave this to your radiology colleague to study the lesion in detail. But remember, you can have a biphenotypic tumor, where the part of the lesion may show you features of HCC, a part may show features of mass-forming cholangiocarcinoma. This lesion definitely needs to be biopsied. We can only suggest that this is likely to be a hepatocholangiocarcinoma, but it needs to be sampled for making a definite diagnosis. So let's move on to seeing metastatic deposits and how they differ in their appearance. Liver is second only to regional lymph nodes as a site for metastatic deposits. The common sites of primary where mets to the liver come from are colon cancers, gastric cancers, pancreatic cancers, neuroendocrine tumors of the pancreas, kidney tumors, and carcinoma of the breast. In today's time, surgeons very often want an assessment of the quantitative load, the number of metastatic deposits, because many patients will be subjected to surgical excision of the metastatic deposits in addition to treating the primary. So assessing the quantifiable load of metastatic deposits is best done using MRI. Hypovascular metastatic deposits are more common. They are best appreciated on the portal venous phase. There are some primaries, however, which produce hypervascular metastases. The typical examples of these are neuroendocrine tumors of the pancreas, or the JEP-nets from the gut, like carcinoids, or renal cell carcinoma. Let's look at some typical examples. Metastatic deposits are most often multiple. They show you rim enhancement. They are multifocal lesions, and they show you washout, which is peripheral. So the features of metastatic deposits would be multiple lesions, usually show peripheral enhancement, and they show peripheral washout, right? So this is again different from HCC, even from a multifocal HCC, which typically shows you non-rim enhancement and non-peripheral washout. So these are important findings. These are some more examples. Again, the typical enhancement pattern of metastatic deposits is this kind of thick, irregular enhancement. And someone had asked a question earlier, how do you distinguish between liver abscesses and metastatic deposits? Well, the enhancing rim of an abscess is typically very thick and irregular. Metastatic deposits tend to have a more uniform rim, and the center is not as liquefied as that of a liver abscess. And of course, the clinical context is also very important. This is the rarer appearance of metastatic deposits, the hypervascular metastases, which can enhance uniformly in the arterial phase, and they may become totally isodense to the background liver. They are more difficult to differentiate from multifocal HCCs. This is a patient who has multiple enhancing lesions in the arterial phase. Notice in the pancreas, you have another enhancing lesion in the head of pancreas with subtle focus of calcification. There was no endocrine dysfunction. In the venous phase, there was washout from these lesions. And because of the presence of this lesion in the head of the pancreas and no endocrine dysfunction, we diagnose this as a non-functioning neuroendocrine tumor of the pancreas with liver metastases. The patient underwent a Dodonok PET CT, and all these lesions were very avidly enhancing on the Dodonok PET, which confirmed the diagnosis of a non-functioning neuroendocrine tumor. Let's look at, very quickly, let's look at some tumor mimics. So fatty change in the liver can sometimes play havoc. It can mimic focal SOLs in the liver. More often you get diffuse fatty infiltration, right? When the liver becomes hypodense on CT and becomes very bright on a T1 weighted image on MR. Remember, MR can also be used to quantify fat, but that's a topic for another day, where there are methods by which you can quantify the amount of fat in the liver. This is a patient where the background liver on ultrasound was looking very echogenic. There was this hypoechoic area. We were not sure, are we dealing with a tumor? Is this a space-occupying lesion? We did a CT, and on CT, the background liver was all fatty, right? Very low in attenuation as compared to the spleen. This area in the center of the liver was relatively hyperdense, but had blood vessels coursing through it. So this is nothing but focal fatty sparing, right? The background liver is fatty, and this is an area where you have focal fatty sparing. It can mimic a space-occupying lesion, and you need to be very careful in trying to diagnose this. We very often use MR. MR can be used, the in and a post-phase imaging can be used. This is an in-phase image, that's in a post-phase image. Notice that the background liver is showing a lot of signal drop, which suggests that there's a lot of fat in the background liver. This mass-like area is not showing you that signal drop, and therefore we were able to diagnose that this is just an area of focal fatty sparing mimicking a tumor. Sometimes you'll see these very well-defined, sharply defined wedges of contrast enhancement in the liver. These are referred to as THADs, transient hepatic attenuation defect, or on MR referred to as transient intensity defects. These usually occur because of occlusion of portal venous branches, where arterial supply takes over. And sometimes a transient hepatic attenuation defect can be an harbinger of a more ominous lesion, as is seen in this patient, This is a THAD, a very sharply marginated arterial enhancement. Within that, there is a focal lesion sitting here, which on biopsy was found to be a metastatic deposit. I'm reaching the last 2 or 3 slides. This is a patient who had Budd-Chiari syndrome. You can see the enlarged caudate lobe, nodular contour of the liver. That's the stent in the middle hepatic vein placed by our interventional radiology colleagues. In NRH, in HVOTO, you can get the entity of nodular regenerative hyperplasia, which can show you arterial enhancement, right? Notice these multiple nodules in the arterial phase. They do not show washout, right? If this was multifocal HCC, we would have expected to see washout. NRH typically can show arterial enhancement, but does not show venous washout. So that's the way of how we can distinguish nodular regenerative hyperplasia from multifocal HCC in the background of HVOTO. One caveat in the context of LIRAD is LIRAD nomenclature is to be used only in adult patients who are high risk for developing hepatocellular carcinoma, which basically means adults with cirrhosis of any kind, with chronic active hepatitis, or any condition which puts them at high risk for HCC. It is not to be used in patients who have normal livers. So you cannot describe focal liver lesions in a normal liver using LIRAD. It's only for adults who are at a high risk for developing HCC. Same way, LIRAD nomenclature is not used for describing lesions in the context of HVOTO or Budd-Chiari syndrome. To conclude, CT and MR are both robust modalities for evaluating focal liver lesions. Ultrasound today is used essentially for screening, or if in the oncology population, if you have a patient with known cancer and you have multiple liver lesions, then you can really straight away go ahead and do an FNAC, and you may not do a CT for those liver lesions unless a CT is required for staging of rest of the disease. I have shown you some examples where biopsy can be avoided if typical liver lesions, if typical features on imaging are seen in lesions like hemangioma, in lesions like FNH. Imaging is actually more reliable than biopsy. Having said that, in day-to-day clinical practice, we see a lot of overlap between lesions. Many lesions do not show typical features, and it is then that we will resort to doing an image-guided biopsy. What is the best tool for evaluating a liver lesion? By all means, it is a multi-phase MRI. If for logistic reasons or for fiscal reasons, you need to resort to a CT, then a multi-phase CT is the next best substitute. Contrast-enhanced ultrasound is a good problem-solving tool after you have done a CT and you're left with an equivocal imaging finding. It's vital to remember some imaging mimics, and I've shown you some of those. Very important to see the background liver and see the presence of chronic liver disease, because your index of suspicion is going to change completely. The one important message for the talk would be multi-parametric contrast-enhanced MRI is the way to go for characterizing focal liver lesions. I thank you very much for your attention, and I'll be happy to take any questions.
Thank you very much, Professor Raju Sharma, for an outstanding lecture. I think a very lucid and a very clear coverage of the topics and the points of on the images rather than going on only on the other parameters and clinical descriptions. And I think you will be interested to know that over 130 or almost 130 questions have come in this short while, and they are still coming in. So in the next about 7 or 8 minutes, I'll try and ask you a few of those and try and keep them down to the short technical ones to begin with. One of the questions that has been asked by Dr. Subhashish from Noida is, are MR contrast agents nephrotoxic and more nephrotoxic than CT contrast agents? And in the same breath, what is your cutoff for serum creatinine levels for using multiphasic CT scan?
So MR contrast agent is not directly nephrotoxic, but in a patient who has deranged renal parameters, we do not use MR contrast because of the risk of a condition called nephrogenic systemic fibrosis. So just as you do not want to use iodinated contrast in a patient with deranged renal functions, you don't want to use it in a person who has deranged renal parameters. You don't want to use MR contrast either. Having said that, on MR, what we follow is the concept of eGFR. in those patients who have EGFR of less than 30 ml, we would not inject MR contrast agent. There are some contrast agents which today people say you can use, and these are macrocyclic agents. So I'll not go into the details, but remember that there are some emerging contrast agents for MR which can be used even when the renal parameters are deranged.
Can I interrupt you for a moment, sir? Dr. Raju Sharma, can you keep your chair slightly back so we can see you full of your torso face while you're responding to questions? Yes, sir. Yes, sir. This is better. Yes.
To continue with the questions, Dr. Gurunath from Hyderabad wants to know what is the role of super paramagnetic iron oxide for HCC imaging, and is this contrast medium available in India? Are Indian radiologists using it?
So super paramagnetic iron oxide agents are not available in India. In fact, the enthusiasm for using them has gone down even in the West. They were used a lot, say about 7 or 8 years ago, but clearly the advantages are not that many and they are considered to be toxic. There's another category of contrast agents which are the ultra small paramagnetic iron oxide, USPIO. Those are still used for lymph node imaging, but not for liver lesions. So Indian radiologists do not use it because it's not available in India. Even in the West, majority of the centers do not use it anymore.
Thank you. I think I'll come to a quick questions about differentiation between common entities. And Dr. Mohammad Rahman Habib from Bangladesh wants to know, how will you differentiate multifocal HCC from macronodular cirrhosis?
So based on the T1 and T2 signal, as I said, regenerative nodules will show you T1 bright, T2 dark signal. HCC will show you T1 dark, T2 bright signal. Exactly the opposite. Same way, regenerative nodules usually do not show contrast enhancement unless the very high grade dysplastic nodules, which may show some arterial enhancement. So regenerative nodules are T1 bright, T2 dark, no contrast enhancement. And HCC is T1 dark, T2 bright, shows you non-rim contrast enhancement and non-peripheral venous washout.
Right. There are a couple of questions on intrahepatic cholangiocarcinoma. One is Dr. Path Shah from Mumbai wants to know, how will it be differentiated from hepatocellular carcinoma? While Dr. Avinash Tiwari from Srinagar wants to know, how would you differentiate intrahepatic cholangiocarcinoma from cholangiolar abscesses?
So let's talk of HCC versus mass-forming cholangiocarcinoma first. As I said, hepatocellular carcinomas show you non-rim enhancement. It shows you heterogeneous enhancement in the center of the lesion. The cholangiocarcinoma shows you rim enhancement. And I showed you that by quite a few examples, that mass-forming cholangios show peripheral or rim enhancement, whereas HCCs show you non-rim heterogeneous central enhancement. HCCs show venous washout, whereas mass-forming cholangiocarcinomas have a very rich fibrous matrix and therefore tend to accumulate contrast in the delayed phase. So those are the two things. Then capsular retraction is seen more often in mass-forming cholangiocarcinoma. Biliary dilatation is seen more often in mass-forming cholangiocarcinoma. These features are not seen so often in HCCs.
I need to get one more request, Dr. Raju. If you can stop sharing your screen, then we can we have a full view of all the moderators. Yeah, absolutely. Yes.
Is that all right?
Yes, much better.
I stopped sharing, Govind.
Yes, sir. Yes, sir. Yes,
sir. Dr. Raju, I think Dr. Yatu from Srinagar.
And to go back to the question.
Yeah. Yes, I thought you were not through with the question. Yes, please. The question that I'm asking now is what are the imaging features for alveolar hydatid? Dr. G.N. Yatu from Srinagar has asked this question. Alveolar hydatid versus...
Alveolar hydatid is a very, very difficult...
Right.
Right, sir. So alveolar hydatid is a difficult lesion to diagnose. It's difficult because it's totally different from the common garden variety of hydatid that we are used to seeing. Alveolar hydatids present more often as solid lesions. They show you central calcification. Firstly, remember, it's a very rare lesion.
Yes.
I think Kashmir, probably in Kashmir, they do see it, but in the rest of the country, alveolar hydatids are very, very uncommon. They can present as mass lesions. They can mimic tumors, but if we look at the clinical features, the history is typically very long. Those lesions will be present for about 4 to 5 years, right? They can show you central calcification but the rest of, and do not show you too much enhancement. So, but having said that, it's a very difficult diagnosis to make, and most often a confirmed diagnosis of alveolar hydatid comes either on biopsy or after surgical excision. We've gone wrong a number of times in trying to distinguish it from tumors.
Yes, indeed. It's a tough challenge there. Dr. Rakesh from Lucknow wants to know differentiating a gallbladder cancer which has infiltrated into segments 4 and 5 vis-a-vis a segment 4-5 HCC on CT. How would you go about differentiating these two conditions?
And that again it's a tough call. We look at the epicenter of the lesion. Where is the epicenter of the lesion located? Is it located in the gallbladder? How much of the gallbladder lumen can we identify? Is the lesion going from the periphery towards the wall of the gallbladder, or has it arisen in the center of the gallbladder and then moved outwards, right? Gallbladder cancers, then we look at locoregional lymph nodes, because in gallbladder cancers, we'll very often see portal lymph nodes, we'll see dilated biliary radicals. In fact, this distinction can be probably better made on ultrasound. I would rely a lot on the ultrasound evaluation of the gallbladder, because I want to look at the whole gallbladder wall. I want to see if the lesion is arising from the gallbladder wall or not. But sometimes if you have a purely exophytic lesion arising from the gallbladder wall, which is infiltrating the segments 4 and 5 of the liver, it can very closely mimic a liver tumor. Having said that, gallbladder cancers do not enhance as much as HCCs do. But occasionally, if you're working in a tertiary care center, you may be encountering a neuroendocrine tumor of the gallbladder, which will enhance as much as an HCC. So tough distinction to make. We would look at the epicenter of the lesion where it's lying.
Dr. Suprabhat Giri from Mumbai has asked an interesting question regarding differentiating a hemangioma versus mass-forming cholangiocarcinoma, since you mentioned that rim enhancement and centripetal filling happens in both lesions.
Yes, indeed. So the early arterial phase enhancement of hemangioma looks different. Remember, I mentioned the typical description is peripheral, nodular, discontinuous enhancement. It is nodular and discontinuous. Those are the absolutely critical words, and that enhancement matches the blood pool. It will be as much as the aorta. In cholangiocarcinomas, you will get rim enhancement, which is not nodular usually, and is not as much as the enhancement of the aorta.
Right.
Do we ask Pankaj to have some questions to take some questions?
So many. You have to tell us how much time that you have.
Maybe 5 minutes more, and then we have some quiz questions also. So
we have a quiz, Govind. We still have to do a quiz.
Yes. So maybe we take 3-4 questions now, and then take 2 quiz questions before we wrap up.
There are so many questions. I don't know where we should start from. There are about 100. We'll never finish. So I think I'll start from the other end. Some of them actually are probably not related. It's about giving GCSF and SBP, and we stay away from those. And so what is the role of liver volumetry? We haven't discussed that. If you have any comment on that, sir. Can you hear me?
So yeah, and time constraints wouldn't permit me to go into liver volumetry, but clearly it obviously has a role in assessing the FLR whenever a patient is being considered for resection of a liver lesion. I thought it would be of more greater interest to surgical colleagues who always ask us to do liver volumetry to assess FLR going ahead with resection of a liver lesion. There are reliable softwares now available on CT as well as on MR, which can help you to assess the functioning liver reserve after they have resected. Surgeons can actually sit on workstations and do simulations of how much they are going to resect and how much they are going to leave behind. So huge role in the GI surgical practice in patients who are being planned for surgery.
Binila Jose from Tiruvalla, who's asked, how do you interpret calcifications in lesions in the liver?
So the lesions that we've talked of today, if I see where does it really help us to characterize a lesion, fibrolamellar HCC is one thing that comes to mind, because the scar of fibrolamellar HCC frequently shows calcification. If I see a scar which has calcification within it and the lesion is enhancing with venous washout, I would be thinking on the lines of fibrolamellar HCC. The other lesions which can show calcification, of course, are metastatic deposits which come from mucin secreting primaries. We know that mucin secreting primaries from the stomach or from the ovary can show you calcification. So that's another place where we look at calcification, because sometimes it can help us in trying to say where is the primary lying for that metastatic deposit. Then there are some lesions which never show calcification. For example, focal nodular hyperplasia almost never shows calcification. So the absence of calcification is also important in some lesions.
So Dr. Raju, you mentioned about ADC map. So there's a question from Chennai. If you could tell a little bit about what a ADC map is.
I think some bit of radiology should be left to the radiologist. We always have this struggle with gastroenterology in our hospital. The trouble with our gastroenterologist is they know too much radiology, and that's why your radiologist is as good as the gastroenterologist wants him to be. You have to push him to his boundaries. But so ADC is a mathematically calculated image from your diffusion weighted sequence. And if I was to just give a one-line take-home message on how the ADC map is used in the context of looking at liver lesions, if a lesion is bright on an ADC map, it's a lesion which is not very cellular and not of that much clinical concern. It is the lesions which are dark on an ADC map, which we are really worried about when we are dealing with our gastroenterology colleagues. The physics of it is way too complicated, and I would give a separate talk on just on how do you do diffusion weighted imaging actually. I don't know if I satisfy the question, but it's not much.
Pankaj, can we,
questions asked about?
Pankaj,
Should we start?
No, can we stop here and say, just two questions? Two questions. One is simple, that in India, tuberculosis, the question is tuberculoma. Are there any specific features by which we can say this is tuberculoma, or you have to do biopsy?
TB in the liver, no, there are no specific features. TB in the liver, sarcoid in the liver, very, very difficult to diagnose. Most often we see multifocal lesions. At best, we could be able to suggest sometimes that it's a granulomatous lesion. We would never be able to suggest that this is TB of the liver. Yeah. In some situations, I know when we see multifocal lesions, which show you some peripheral enhancement, you have lymph nodes at the porta, you have lesions in the spleen, then we have suggested at times that these are granulomatous lesions, could be TB, could be sarcoid. And then you need to sample them. But is there any imaging feature which can diagnose TB in the liver? No, none to my knowledge.
And the last question we want to ask you is Dr. Ramesh Garg from Delhi, PET imaging in liver as well. Short answer.
So PET is typically not used to characterize liver lesions. It's just not a good enough. And people will argue that PET CT gives you CT information as it is. But unless a PET CT is being done in an oncology patient for staging otherwise, and they can detect liver metastases, or you do Dodonok PET for neuroendocrine tumors to make that diagnosis, I see no role for PET CT in characterizing an unknown liver lesion. That has to be done using multi-phase MR. And as I said, as a second best substitute, a multi-phase CT.
So would like to put some quiz questions. For that, you have to share your screen. So what Dr. Raju Sharma will do now is put 2 or 3 quiz questions, show some images, and look forward to see your responses. So Dr. Sharma will show the question, and you will find on your screen 4 choices. And as you get choices, please respond to those choices, and we'll see that what are the responses in that.
So is my screen visible?
Yes, sir.
Okay, so we have put together just 4 cases in the interest of time. I'll show you images, and I was advised that there will be some lag after I show the image up to the time that you can answer the question, and then there's some kind of a poll. So the first image is of the 62-year-old male patient who had chronic active hepatitis. And this was the CT that he underwent. These are the arterial phase images. The first panel is the arterial phase. The second panel is of the venous phase image. And the question you have to answer is, what is the LIRAD category of this lesion?
So the question is, the choices are given here. And the choices are between LRM, LR5T4, LR4, and LR3. So you have to choose and poll accordingly. I think the answers would be coming in. These are the answers which have been given by people.
So very good. I think most of you have got it right. This is indeed an LR5 TIV lesion. And if I can go back to my screen for a moment, the reason this is LR5 TIV is firstly, we can apply LIRAD. It's not a trick question. You can apply LIRAD because patient has a condition which puts him at high risk for developing HCC. The lesion is in the left lobe, segments 2 and 3 of the liver, shows you non-rim arterial phase enhancement. And on the venous phase, it shows you washout. And this is the portal vein. And this is the filling defect within the portal. Any biopsy, no further confirmation, and they can go ahead and treat this as an HCC. Okay, very well done. This is LR5 TIV for a patient who has chronic active hepatitis. Okay, this is case 2. This is a 55-year-old lady who presented with anorexia, and these are the arterial phase images. These are some coronal reformats of the arterial phase, and these are the venous phase images. And the question to you is, what is the diagnosis? Are these multiple hemangiomas? Is this multifocal HCC? Are these multiple metastatic deposits, or is this polycystic liver disease?
Can we have answer, Amol?
We're wondering if the same slides were shown by Dr. Raju earlier.
So this is a like Raju.
I think we have very smart people. They have majority of them have got the answer right. This is indeed metastatic deposits, multiple metastatic deposits, and the reason these are metastatic deposits. Notice that firstly there are multiple lesions. They show peripheral enhancement. All of them show peripheral enhancement, and there is a peripheral washout. So there's a rim enhancing here, and that rim is the one which shows washout. When you look at metastatic deposits, remember you have the rest of the CT also. So there are lymph nodes seen here, right? Large lymph nodes. So this was a disseminated malignancy. If this was polycystic liver, remember none of these lesions would have shown any enhancement at all.
I think we can stop here for this quiz, and then we go to last part of our talk. Thank you so very much, Dr. Raju Sharma, for a wonderful talk, and we really enjoyed the way you described each and every aspect of the lesion in the liver. Remarkable. This is remarkable. So simplistically, sir, explain to us when to do what imaging and what are the features in different imaging is so remarkable. Thank you so very much for that masterly talk. I think all of would have enjoyed. We would like to clap for you, but this is not a platform where we can clap. But certainly we can say that this was a so wonderful presentation by you. Thank you so very much. Thank you, Dr. Pankaj, for moderating this session.
Thank you very much, Govind. Thank you for inviting me.
So this has been thank you so much, sir. Thank you, Dr. Pankaj Puri, for a wonderful moderation of this session. And we believe that the gastroenterologists have to have some knowledge about how do you interpret liver imaging. And more importantly, choose the right imaging for right kind of patient. Like we see that a lot of patients come with a they just come with a CECT without a multiphasic state, and then we have to repeat once they come to advanced centers. So it's always good to choose the right imaging, which is extremely important. This program was seen by almost more than 1,000 people, both live and both on the Facebook too. And as you know that we are going to put this lecture into ISG library and also on the Facebook, so you can see these lectures much later at your convenience. And we want to revise some of the point that we can do at later point. As we said last time, that we will extending the duration. We'll be continuing with master classes. After the present 12, which are listed master classes, we'll add then we go once weekly on Sunday, and we are updating the list of master classes on the ISG masterclass website. Now, coming in the same vein, now we have next lecture by Dr. Anil Arora on a very important topic, that is how do you treat hepatocellular carcinoma. And this in fact will be extension of continuing of this talk on liver SOS imaging. Then how do you treat these lesions will be next talk on Wednesday 5 to 6, that is May 20th. Dr. Anil Arora will talk on how do you treat liver SCC, how do you treat hepatocellular carcinoma. With this, we thank you everyone. We thank you all the participants from not only from India, from many other countries. We have a participant for almost 15 countries who joined these master classes. Thank you everyone. Thank you Dr. Saraswat again. Thank you Dr. Puri. Thank you Dr. Saraswat. Thank you technical team, and thank you everyone. We'll see you on next Wednesday at 5
Thanks a lot, Govind, for inviting me.
Another talk on SCC. Bye-bye. Thank you so very much. Thank you so much. Bye.